early stage breast cancer. Unfortunately, Dr. Haris sir couldn't join right now because he caught up in some important work. He will join as soon as he is free. So our first session is surgical management. Surgery has been mainstay of the treatment. Several landmark studies paved the path towards current nodal management. Surgical Dr. Shubham is going to present surgical anatomy of axilla and nodal management in early stage breast cancer. And this session is mentored by Dr. Rajiv Agarwal, Senior Director and Chief Surgical Oncologist at Medanta, the Medicity. Dr. Vedant Kabra, Principal Director Surgical Oncology, Fortis Hospital, Gurgaon. Dr. S.V.S. Dev, Director Surgical Oncology, All India Institute Medical Science. Warm welcome to our mentors in this forum. Dr. Shubham?
Yes, ma'am.
Yeah. Over to you, Dr. Shubham.
Okay, ma'am.
Kindly start your presentation.
Yes, ma'am. So, is my screen visible?
Yes, Dr. Shubham, it's clearly visible.
Okay. So, good evening, everyone. I am Dr. Shubham Pandey, third year surgical oncology resident from Max Super Specialty Hospital, Saket. So, the topic that I will be discussing today evening is surgical anatomy and nodal management in early breast cancers. Axillary management of patients with newly diagnosed breast cancer has undergone several practice-changing paradigm shifts over the last few decades. The ultimate goal of reducing morbidity without compromising on the oncological outcomes. So historically, as we all know, that surgical management of axilla was viewed as a prognostic indicator of disease and long-term survival, and it significantly impacted adjuvant therapy recommendations. But more recently, there has been a shift towards less extensive axillary surgery in both clinically node negative and clinically node positive population. The increasing use of neoadjuvant therapy in early stage breast cancer patients has presented a challenge in determining the extent of axillary surgery necessary for axillary staging and loco-regional control. Previously, when the Halstadian principle of radical mastectomy was introduced, the axilla was seen as a transit point between the breast and the distant metastatic disease in the body. But later on, eventually it was known that breast cancer does not follow the Halstadian principle of local disease followed by regional disease, then spreading to metastatic. But there are many cases in which there could be skip metastasis to other stations as well, and systemic metastasis without nodal involvement. It was believed that removal of axillary node was necessary to prevent distant metastatic spread. But as the understanding evolved, removal of these lymph nodes was not viewed as a necessary procedure to prevent spread, but rather an important component of breast cancer staging and prognosis. Identification of lymph node metastasis directed clinicians to offer systemic therapy and to consider radiation therapy to chest wall and nodal basins. So coming on to the lymphatic drainage of breast, it begins from the subareolar plexus of Sapi. From there, it could go to various lymph node stations. The lymph node stations in breast is classified according to 3 levels based on the anatomical locations with respect to the pectoralis minor muscle. The lymph node stations, which are lateral to the lateral border of pectoralis minor, are termed as level 1 lymph nodes. The nodes which are exactly posterior and behind the pectoralis minor muscle are termed as level 2 lymph nodes. And the lymph nodes which are medial to the medial border of pectoralis minor are termed as level 3 lymph nodes. So level 1 lymph node includes 3 group of lymph node stations, that is anterior or the pectoral group, the posterior or the subcapsular group, and the lateral or the humeral group. The 2 lymph node stations which are included in the lymph node level 2 are central group of lymph nodes and interpectoral, that is Rotter's group of lymph node. And level 3, that is apical or infraclavicular lymph nodes, as station 3 lymph nodes. Coming on to the surgical anatomy, these are other important landmarks which we encounter in doing generally axillary node dissection in a mastectomy specimen. So few important landmarks are intercostobrachial nerve, which is present and crosses the second interdigitation of serratus anterior. And it is an important structure which is a pure sensory nerve and supplies the sensation to the skin of the lateral chest wall, medial side of the arm and the axilla. The effort should be made to preserve this nerve. Two another important nerves with respect to axillary dissection are nerve to serratus anterior and nerve to latissimus dorsi. So in this diagram, this is the surgical diagram after level 3 clearance of the axillary nodes. We can very well see a transverse nerve, that is an intercostobrachial nerve, and the two parallel nerves perpendicular, which are coming from the axillary vein. The medial one, which runs along the lateral border of serratus anterior, is nerve to serratus anterior or the long thoracic nerve, and the another nerve, which is lateral to the that nerve, is LD pedicle. Along with the LD pedicle, that is nerve to latissimus dorsi. Now, moving on to the important landmark trials which shaped the axillary management in patients with breast cancer over years. The first trial that we could recall, a landmark trial, was an NSABP04 trial, which was initiated in 1970s. The goal of B04 trial was to determine whether less extensive surgery with or without radiation therapy was as effective as the Hallstadian radical mastectomy. A total of 1079 patients with clinically negative axillary nodes were randomized to 3 groups. The first group was radical mastectomy. The second group was total mastectomy without axillary dissection, but postoperative radiation, including the chest wall and axilla. And the third group was total mastectomy alone, in which axilla was not addressed. So this trial showed no difference either in overall survival or distant disease-free survival in either group of patients. The last follow-up that was published showed that these results were consistent at a follow-up of 25 years. The trial had a separate arm that included patients with clinically positive nodes, which were randomized either to Hallstadian radical mastectomy or total mastectomy with axillary radiation only. Patients with clinically positive node did not present any difference in survival, whether the axilla was treated with either surgery or radiation therapy. In women with negative node, there was difference in cumulative incidence of local or regional recurrence. This was the only parameter which was found to be different in the patients in which axilla was not addressed, but rather rest all parameters of survival and distant disease-free survival were absolutely the same. There was no difference in those. A total of 68 out of 365 women who underwent total mastectomy alone recurred with the axilla. That is 18.6% patient had an axillary recurrence. The median time of axillary recurrence was approximately 15 months. And another point to note in this trial was that approximately 40% of the patient who had mastectomy alone had positive axillary nodes that were not removed at the time of initial surgery. But the point was, even if the axillary nodes were positive, those were not addressed. That does not make a difference in overall survival or disease-free survival, posing a question that whether addressing axilla with surgical or radiation is important to prolong an overall survival in breast cancer management. So these data are important because they indicate that leaving positive nodes without surgery or radiation therapy did not significantly increase the rate of distant recurrence or breast cancer-related mortality. The only drawback of this trial was that it was not powered enough for axilla. And then further, these data was used, incorporated to design an ACOSOC Z11 trial that I am going to discuss further. After the introduction of a novel modality called sentinel lymph node biopsy by Armando Giglioni in 1990s, there was another landmark trial, NSABP 32, that was a phase 3 randomized trial comparing axillary resection with sentinel lymph node dissection compared with ALND. So the inclusion criteria were invasive breast cancer, clinically node negative were included. Patients were then stratified according to age, tumor size, lumpectomy, total mastectomy, systemic adjuvant treatment received, and according to those groups, the patient was randomized to undergo sentinel lymph node biopsy followed by ALND in all patients, irrespective of the results of sentinel lymph node biopsy in group 1, and second group, sentinel lymph node biopsy followed by complete ALND only in the patients in which sentinel lymph node biopsy was turned out to be positive. So it was a largest randomized surgery performed in breast cancer patient. Dual tracers were used to perform SLNB. 2 mm sectioning of the nodes with routine H&E staining of each section was used. IHC was not permitted for routine patient care except to confirm suspicious equivocal cases. Regional recurrence rate were less than 1% for both the groups, whether sentinel lymph node biopsy was followed by ALND or whether only positive sentinel lymph node group was followed by ALND. So this trial demonstrates that again, overall survival, disease-free survival, and regional control were all statistically surgery alone. The survival was less than 2% in both the groups. The group 1, 75% patient had only one positive non-sentinel node, and 95% of this subset was treated with some or the other form of systemic adjuvant therapy. So the outcome of these patients was not inferior to rest of the group as a whole. Coming on to the second group, that is the only sentinel lymph node biopsy group, a similar subset of non-sentinel node positive patient was expected, but since those patients in which sentinel lymph node biopsy was negative were not further addressed by any modality, but rather was kept on follow-up, so that could not be that comparison could not be made out. So NSAP B32 trial concluded that it confirms low rate of regional nodal recurrence following sentinel lymph node surgery. B32 trial also validates that when sentinel nodes are negative, there is no significant difference in regional nodal recurrence between if complete axillary nodal clearance is done or only sentinel lymph node resection is the only modality. Now, till NSABP 32, it was clear that in those subset of patients in which sentinel lymph node comes out to be negative, those patients can be kept under observation. No need to undergo complete ALND. Now, there was another trial, the ACOSOC Z11 Alliance trial. This trial was a phase 3 randomized clinical trial which enrolled patients from the year 1999 to 2004. And the eligibility criteria for these patients were T1, T2 invasive breast cancer with no palpable axillary lymphadenopathy, but on performing a sentinel lymph node biopsy, there was 1 to 2 sentinel lymph nodes positive. And then those patients were randomized. So this ACOSOC Z11 trial had a very selected group of breast cancer patients, rather early breast cancer patients with only 1 to 2 sentinel node positive patients. The patients, 100% of the patients underwent breast conserving surgery, which was followed by some form of systemic therapy and whole breast irradiation with tangential rays addressing the axilla. So the finding of this trial after a median follow-up of 9.3 years was overall survival for patients treated with sentinel lymph node dissection alone was not inferior to those treated with completion axillary lymph node dissection. That is 86.3% versus 83.6% in the completion ALND group. So this trial addressed that in a very specific subgroup of breast cancer patients, even after there is 1 to 2 sentinel lymph node positive in the SLN biopsy, those patients, if breast conserving surgery is given, 100% of those patients are planned for whole breast irradiation and some form of the adjuvant therapy. Even after 1 or 2 sentinel lymph node positive patient, those patients can be kept for observation without performing a completion ALND. So there was coming to the discussion of this ACOSOC Z11 trial, no difference in overall survival between the two groups with low rates of loco-regional recurrence in both. 10-year follow-up data continued to show the same results. The cumulative incidence of nodal recurrence at 10 years was 0.5% in the ALND arm and 1.5% in the SLND arm. And it also addressed that axilla-related morbidity, the complications after ALND, that is lymphedemas, paresthesia, or the shoulder dysfunction, was selectively very less following sentinel lymph node biopsy. Then came the Almanac trial. This was a trial which the primary endpoint of which was axillary morbidity. The Almanac trial primarily focused on the axillary morbidity and health economics of sentinel node biopsy compared to conventional axillary procedure. The quality of life in patients who undergo an axillary procedure compared to those who undergo sentinel node biopsy. So the result shows that the relative risk of any lymphedema, sensory loss for the SLND group compared with the ALND group at 12 months was 11% versus 31%. The drain usage, length of hospital stay, time to resumption of normal day-to-day activities after surgery, all were statistically significantly lower in the SLND group. Overall, patient recorded quality of life and arm functioning score was statistically better with the SLND. These benefits were seen with no increase in the anxiety levels in the SLND group of patients. So it concluded that sentinel lymph node biopsy is associated with reduced arm morbidity and better quality of life than standard ALND treatment. Now, there was another trial which was done in the Tata Memorial Hospital, which addressed that sentinel node biopsy was initially conceived as an excision of the first station axillary lymph nodes, identified by radioactive dye or the blue dye. But the definition subsequently enlarged to also include palpable nodes in the vicinity of sensory node. This trial was basically designed for a setup in which the expertise of sentinel lymph node biopsy, a gamma camera, a nuclear medicine department is not present. So in those patients, an anatomical boundary of a lower axillary sampling was defined, and a lower axillary sampling tissue was done in all the patients. And a false negative rate was compared with the standard sentinel node biopsies. So the technique that they used was a subdermal injection of 0.5 ml 99 technetium labeled sulfur colloid was given 2 hours prior to surgery. 10 minutes before commencement of axillary dissection, another blue dye was injected. A wait period of 10 minutes was seen. Each patient underwent a lower axillary clearance and identification of sentinel node in the excised specimen, followed by complete ALND. So LAS, that is lower axillary sampling, was defined as excision of all the fibrofatty tissue overlying the second digitation of serratus anterior, below the intercostobrachial nerve. So this diagram depicts the boundaries of lower axillary clearance specimen. So what results that this study showed was lower axillary sampling had a false negative rate of 10.5% and a negative predictive value of 94.8%, while those patients who underwent a sentinel lymph node biopsy, the false negative rate was 12.7%. So an analysis was performed to compare cost per patient of low axillary sampling versus sentinel node biopsy. The costs considered were those of a gamma probe, radiocolloid, scintigraphy charges, blue dye, and surgical time. With these assumptions, cost per patient of sentinel lymph node biopsy was 23% more compared to the lower axillary sampling with comparable false negative rates. So in limited capability setups where the facility of sentinel lymph node biopsy was not present, this trial provided another way of axillary sampling as a lower axillary sampling method. So till now, what we've discussed is patients in which axillary management is done who are addressed for upfront surgery. But what about the group of patients who in which axillary management after neoadjuvant chemotherapy? Now, neoadjuvant chemotherapy was largely in patients with inoperable breast cancers. Its indication subsequently broadened to facilitate breast-conserving surgeries in women with larger tumors. All clinical trials on axillary management have been performed on patients undergoing upfront surgical management, and their applicability to those receiving neoadjuvant chemotherapy was not well defined. Clinically node-negative patients prior to neoadjuvant chemotherapy, the initial concerns regarding the reliability of SLND after NAC, its feasibility and accuracy has been demonstrated in multiple studies. The false negative rates and the SLN identification rates were optimized with the use of dual tracer dyes and removal of at least 2 to 3 sentinel lymph nodes in post-neoadjuvant settings. But those group of patients who were clinically node positive prior to receiving any neoadjuvant chemotherapy patients. So the definition was a clinically positive node is defined as an abnormal axillary lymph node identified via either clinical examination or sonographic evaluation, which was confirmed with an FNC. Historically, all clinically node positive patients underwent an ALND following NSC, regardless of the observed response to treatment. But current data suggests that a pathological complete response can be seen in axilla in 12 to 65% of the patient, depending upon tumor subsite, which is 50% in triple negative breast cancers and almost 65% in HER2 positive cancer. Since the response rates to neoadjuvant treatment are quite good, the need to immediately proceed to an LND has been called into question. So there were several trials which addressed this issue, that whether a sentinel lymph node biopsy can be performed in a post-neoadjuvant setting, what was the adequate timing of performing a sentinel lymph node biopsy, whether it should be performed before starting the neoadjuvant treatment, whether it should be performed after neoadjuvant treatment before the patient is taken up for surgery, was addressed in various trials. I have discussed here one trial, that is ACOSOG Z1071, with the objective to determine the false negative rates for sentinel lymph node surgery following chemotherapy in women which were initially presenting with biopsy-proven N1 disease. So, to demonstrate the utility of sentinel lymph node biopsy in patients who were initially node positive, a phase 2 clinical trial enrolled 756 women with clinically T0 to T4, N1, N2, M0 patient. Clip placement into the biopsy-proven positive node was an optional criteria. Dual tracer dye was used with both blue dye and radioactive colloid. The protocol required resection of at least 2 sentinel lymph nodes. Few studies have categorized that at least 3 sentinel lymph nodes in a post-neoadjuvant setting should be removed. All patients underwent a sentinel lymph node biopsy followed by an ALND. The primary endpoint was to determine a false negative rate in a post-neoadjuvant setting. Following chemotherapy, 41% of the patient had a nodal pathological complete response. 310 patients had residual nodal disease. In those 310 patients, 39 patients had a false negative SLNB, resulting in an FNR of 12.6%. The FNR fell further to 10.8% when dual tracer was used. The combination of dual tracer, removal of at least 2 lymph nodes, further brought down the false negative rates to 9.8%. A recent analysis of this particular study sought to determine that if clip placement in the biopsy-proven positive nodes with confirmation of removal of the clipped node at the time of surgery would improve the FNR or not, which gave the concept of targeted axillary dissection. This technique further brought down the false negative rates to as low as 6.8% in a post-neoadjuvant setting. So these are another trials which assessed the accuracy of sentinel node biopsy after neoadjuvant chemotherapy in patients with lymph node involvement at presentation. That is Z1071 Sentinel and FNSC. All these show that false negative rates can be brought down after performing a proper protocol-wise dual tracer technique and removing at least 3 or at least 2 lymph nodes in a post-neoadjuvant setting. The FNR can be brought down to as low as 4.9%. Then there are further de-escalation trials which are going on in the axillary management of early breast cancer, addressing the effects of even macrometastasis after in patients of early breast cancer, that whether to perform an ALND or ALND could be avoided with respect to other adjuvant treatment. These are the some de-escalation trials which are comparing different modalities: sound trial, the Nodal trial, and the POSNOC trials. But due to the time constraint, I'm not going to discuss all these trials in detail. So coming on to the conclusion from the surgical point of view, that axillary management for breast cancer patients has changed tremendously over past few decades. The use of sentinel lymph node biopsy over ALND has the benefit of reduction of morbidity while not compromising on staging, survival, or loco-regional recurrence. Use of dual tracer SLNB targeted axillary dissection is showing promising results in post-NACT clinically node positive patients. the increasing effectiveness of adjuvant systemic and local therapies has been key to these advances in surgical care. There are ongoing trials and future studies will further delineate the extent of axillary management for selected subsets of breast cancer patients. These are the current 2023 NCCN guidelines, which incorporates the results from the Z11 trial and the Amaros trial, that in selected subgroup of patients, T1, T2, 1 or 2 sentinel lymph node positive patients in which whole breast irradiation is positive, in those patients, a completion ALND can be avoided. So this has been incorporated into the NCCN guidelines as well. Thank you.
Very nice presentation, Dr. Shubham. You presented such a vast topic in very concise manner. I request our mentor to share their valuable insight on this topic.
Vedant?
You can start, Dr. Rajiv Agrawal.
I think Shubham has presented very well and summarized the whole thing very well. But to be practical, one thing, clipping of the node is not done in every center. So the message should not go that from tomorrow morning, we should start doing clipping of the node. Second, for per primum surgery, for N0 axilla, sentinel node biopsy has become a standard of care. As the indications for NACT are increasing because of the triple negative and HER2 positive diseases, even 2.5 centimeter tumors with N0 are going. So initial clinical N0, the sentinel node biopsy is definitely going to be a very standard of care in most of the centers who are practicing large volume of breast cancer treatment. Clinically, N1 followed by post-NACT N0 disease has not become a standard of care. And I think before starting as a routine, the center should do their own homework and a learning curve and then start doing it. That is all I can say. But yes, of course, the de-escalation of the axilla is going to be a norm in the near future. Vedant, please.
Thank you, Dr. Agrawal. And I must say, Shubham, you have presented very well. But I have a few points as well as few questions to ask. Are you aware of any Indian studies of post-NACT SLNB?
Yes, sir. There has been a series published by Dr. Somasekhar in post-neoadjuvant setting with a sentinel lymph node biopsy, in which they've seen that using a dual tracer technique with or without an axillary clipping, the false negative reads can be brought down. I'm not aware of the exact values.
Okay. And there have been studies from SGPGI and TMH as well. So there were questions asked by Dr. Charu and Dr. Vinita about clipping. Is it necessary? Is it done? And as Dr. Rajiv Agrawal said, I am not aware of any center in India which is currently doing SLNB post-NACT in N1 converted to N0. There are maybe a couple of them who are validating their data. They are clipping the nodes and then removing the clip nodes along with dual tracer. And as far as I remember, you mentioned, Dr. Shubham, about 2 or more nodes, but as far as I remember, it should be 3 or more nodes with dual tracer.
Yes, sir. It was different in different studies, but
but largely accepted norm is 3 or more. So
correct,
if you have to talk about it in examination, don't say 2, say 3 or more. That would avoid trouble.
Sure.
And yeah. So this is one. Clipping of the node, yes, it is not being done. In fact, there are some centers which are not practicing even outside. So we recently had a speaker from Cleveland Clinic, and they said we have not been using clip nodes, clipping at all. They are using dual traces, and they are almost always able to find 3 or more nodes. So that may answer your question, Dr. Vinita and Dr. Charu, that clipping may not be necessary, but before that we have to validate our own data.
Yes.
Now there are also trials which are comparing, or one trial at least I'm aware of, which is comparing surgery versus RT in post-NACT N0 axilla by the name Taxis trial. Maybe you can go through it. There are trials which are trying to omit even SLNB altogether, not only in upfront setting like a sound trial, But also
Yes.
in post-NACT setting, there are a couple of trials which are going on.
Yes,
The
sir.
name ASICS from Netherlands and UBreast in Europe.
Yes.
And I think you can go through them as well. Apart from clip, there are other materials also which have been used, like mag seed, radioactive iodine seed, carbon particles, and all those to mark the nodes and then remove them during post NACT SLNB. But as of now, it is not yet the current standard of care, at least not in our country.
Thank you, sir.
Any other question from the audience? May I ask you something else also? Do you know the weaknesses of Zoo 11 trial?
Yes, sir. Sir, the recurrence rate, the axillary recurrence rate was very low in the it was less than I think 1% in the Z11 trial. That was one of the drawbacks of that trial. And second was
So it resulted because of what?
Sir, all of the patients
Axillary
were
recurrence was expected to be low. Axillary
yes,
recurrence
sir.
was expected to be low, although it was 3 times more in the SLNB arm. Still,
Yes,
it did not show significance. Why?
Sir, because of the adjuvant treatment that was given to the patient in the form of whole breast radiation, in which the tangential rays address the level 1 and level 2 axillary nodes.
So that was one. The other one was the planned accrual, or actual accrual was actually half the planned accrual.
Yes.
So once you don't accrue the total numbers that you have planned, the power of your trial goes down.
And the selection of the patient was very, very highly selected.
Highly selected patients. So their
Yes.
average breast tumor size was very small. But so Dr. Vinita says the biggest trouble in Z11 was that there was no radiation oncologist as a trial investigator. So that's also an important point, because you have to have a quality assurance for radiation being given, which was a problem in this case. And low axillary radiation was definitely going, tangential field were going there. Yes. Even with Amaros. So what is your opinion about treating axilla as per Amaros? You have found a sentinel lymph node which is positive. Would you like to complete the axilla? Would you send the patient for radiation?
Sir, I would like to do a complete axillary dissection, sir. Those
complete axillary dissection. Okay,
yes.
So the radiation oncologists are already smiling.
Yes, sir.
And why would you want to do that?
Sir, sir, I know that although the complication rates were less, and Amaros trial said that those patients can be taken up for if the chest wall radiation and the nodal basins are being irradiated, so LND can be avoided in certain subset of patients even after a mastectomy with lesser complications compared to the LND group. But still, I feel, sir, what we practice is that if sentinel node are positive, then we, on those patients, we follow complete axillary nodal dissection, sir.
So we are following it because we are doing frozen section, right? And something which is right in front of your eye is positive on frozen. It's very difficult to leave them, unless it is a micrometastatic disease only in one of the nodes. No.
Yes.
Otherwise, it's very difficult to leave it. But if you find it on histopathology, would you go ahead and do axilla, or would you send for radiation? So anyways,
yes,
see, the radiation oncologists keep saying that the lymphedema rates are almost double with surgery as compared to radiation. But if you go back to details of Amaros, that lymphedema rate has not affected the quality of life associated with lymphedema. That's one part. The second part is my personal communication with some radiation oncologists who have special interest in breast radiation. They said that planning radiation for only axilla is not a joke, and it's not an easy job, and it's very difficult. I would like comments from Dr. Charu and Dr. Vinita.
And before you do that, I'll just like to ask, I'm Dr. Geeta. Amaros trial, what was the number of lymph nodes? I've asked if you have to look at the original trial to know what the number is, and that is kind of mind-boggling. So N2 disease is also part of the recruitment. N2 up to 9 nodes. So that really beats me. So I want comments from the radiation oncologist as to how do they factor in those patients who are actually N2 and you're still thinking that you can actually treat the axilla with radiation.
So I think Dr. Geeta, like you very rightly said, I think the other day we were discussing like what was the number of the lymph nodes that was included in the Amaros trial, the highest number. And since you have looked into it, and they have included patients with approximately up to 9 lymph nodes positivity. So we can see that radiation does an equally good job. And as Dr. Vedant was referring to, now we have started getting patients where the frozen section came out to be negative, and in the final histopathology on SLNB they came out to be positive. So still we are going slow in the sense that we see that the patient is slightly older, hormone positive. We go ahead and treat those patients with radiation. So that is on Amaros. And I think the lymphedema, because I think it would take a longer period of time. We have 10-year results with us, still longer to see whether this lymphedema is really affecting the quality of patients or not. Over to you, Dr. Vinita.
So I think, Charu, there is a lot of variability in the practice. I am still very uncomfortable in doing axillary radiation. Even I don't follow what is done in the Amaros study. And even if I have a patient who has frozen negative and paraffin positive axillary, 1 or 2 nodes positive, I would still probably treat only low axilla and not the entire axilla.
So that's again coming from another radiation oncologist who has interest in breast oncology. So there are problems, right? There are problems in radiating axilla and planning for axilla. Yeah, I think that's all from my side. There's another question. ACSOG is about BCS and ALND. What about a patient who is undergoing mastectomy? Dr. Shubham.
Hello, am I audible?
Yes, you are.
Yes, sir. So, sorry, sir. The voice is correct. Sir, can I please the question? Can I hear the question once?
The question is there in the chat box. ACSOG is about BCS plus ALND. What about a patient who is undergoing mastectomy?
So, sir, in mastectomy patients also, if it is a clinically negative axilla, prior to taking up the patient for surgery with a proper ultrasound and an FNAC negative on a suspicious node, in those patients we can do a sentinel lymph node biopsy followed by frozen section and then proceed. Whether if a sentinel node is positive on frozen section, going for a completion axillary node dissection, or just doing a mastectomy and a sentinel lymph node biopsy.
No, I believe his question is if there is a positive node on mastectomy, right? Dr. Alauddin, could you please clarify your question?
Yes, sir. So, good morning. I am Dr. Alauddin from JNMCH. Am I audible?
Yes, you are.
Sir, actually, my question is like ACSOG 001 is about BCS plus sentinel lymph node biopsy, where already there's a planned radiation that we are going to give whole-based radiation, in which level 1 and some part of level 2 axilla are already covered. And what if a early stage breast cancer coming to a surgeon and they are planning for mastectomy, and then what will they do? They will do with axilla. Would they dissect axilla or leave the axilla? And is it sentinel lymph node biopsy is enough for leaving the axilla in that case?
Sentinel lymph node biopsy is enough if it is a negative node. And if it comes out as positive, then Dr. Shubham has already told you that he would prefer to dissect the axilla. And most of us do. If it is macrometastatic disease on frozen section, we would dissect the axilla.
So in the ABCSD 23,
they have included
included mastectomies, although they constitute only 10%, but they have included mastectomies. But in that study, it was micrometastasis.
Yeah.
So you cannot. I don't know how much you can extrapolate. So you must realize that we treat different size diseases as compared to what the West treats. That must always be in your mind when you're treating the axilla also.
Okay.
That is
so-
another question. Like T1, T2, everyone is comfortable doing sentinel, even up to T3. What about like, mastectomy if you are doing for a T4? I mean, I don't think so anyone will be really, delving into sentinel.
Mhm.
No.
No, we are not. We are not comfortable with that.
See, the thing is, when the sentinel node biopsy trial started, it was effectively for up to 3 centimeters. Even the entire T2 was not included. And then subsequently it became T2. T3 is also gray. T3 is gray. T4B is a certain no.
Okay, so that's all from our side, Dr. Garima.
Thanks a lot, sir, for being a part of this forum despite of busy schedule. Now, we witnessed the paradigm shift of LND to SLNB in surgical management. So how the role of the radiation has evolved in EBC is going to present by Dr. Alka Parva, Senior Resident, AIMS Kalyani. And our mentors are Dr. Piyusha Kulshesh, Senior Consultant, Radiation Oncology, Metro Hospital, Delhi, Dr. Sweeti Gupta, Associate Professor, Radiation Oncology, AIMS, Rishikesh, and Dr. Prekshi Chaudhary, Senior Consultant, Max, Vaishali. Dr. Alka, kindly start your presentation.
Yes, ma'am. Am I audible?
Yeah.
Is my screen visible, ma'am?
Yes, it is visible.
Okay, thank you, ma'am. Good evening. Today the presentation is on overview of nodal irradiation in early breast cancer. I'm Dr. Arkaprabha Sinha, SR Radiation Oncology from AIMS Kalyani. So the contents will be lymphatic drainage, patterns of nodal failure in breast cancer, why to treat nodal stations and how nodal stations are addressed, nodal treatment of clinically negative and positive axilla, role of regional nodal irradiation after neoadjuvant chemotherapy, indications of each nodal station, and future directions. So according to NCI,
Excuse me, Dr. Arka. Your presentation is not visible. Your screen is visible, but your presentation is not.
Just a minute. Is it visible now, ma'am?
Not yet.
Dr. Arkam, you stop sharing and then you reshare the screen. It will be possible then.
Okay, ma'am.
Dr. Arka, have you shared your PPT with Nidhi?
Yes, ma'am. I have shared it.
Ma'am, but the PPT is, it's large. The file is very large. So downloading that is becoming an issue for me.
Dr. Garima, if this is taking time, we can move on to the genomic profiling first. In the meantime, I think Nidhi will be able to download it. Should we do that, Nidhi?
Sure, we can do that, ma'am.
Okay, Nidhi. Dr. Garima, please invite the third speaker first.
Okay, ma'am. So our Our next session is clinical utility of genomic assay in early breast cancer. Going to present by Dr. Krishna Devya, resident Metro Hospital, Delhi. Our mentors for this session are Dr. Devrit Arya, senior consultant, Max Saket, Dr. Atul Batra, professor in Department of Medical Oncology, AIMS, Delhi, and Dr. Shaina Goel, consultant medical oncology, Medanta, the Medicity, Gurgaon. Dr. Krishna Devya, kindly start your presentation.
Yes, ma'am, I'm trying to share it. Ma'am, is my screen visible?
Yes,
Yes, Dr. Krishna.
Okay, ma'am. Good evening, everyone. Myself, Dr. Krishna Divya, DNB Medical Oncology Resident, Metro Hospital, Prithia. My topic today is clinical utility of genomic assay in node-positive early-stage breast cancer. Breast cancer is a major public health problem for women throughout the world. Almost 30% of patients with breast cancer who are free of disease after initial local and regional treatments present with disease recurrence during follow-up. Between 1950 and 2014, the death rate from breast cancer decreased in United States by 38.5%, which is attributed to screening mammography and adjuvant therapy. It implies that adjuvant treatment in early breast cancer can reduce the risk of recurrence. So how do we assess the risk of recurrence in breast cancer patients? Conventionally, clinicopathological factors like tumor size, lymph node status, age, tumor grade, estrogen receptor, progesterone receptor, and HER2 receptor status is utilized. And adjuvant online is a computer-based model which accommodates all these clinicopathological factors and gives a 10-year risk of recurrence and the survival data, and also the benefit of adjuvant systemic therapies. The new tool in this genomic era is genomic assay like Oncotype DX and others. Prior to genomic testing, the decision for adjuvant chemotherapy for early breast cancer was made based on clinical and tumor characteristics such as age, comorbidities, number of lymph nodes involved, tumor size and grade, hormonal biomarkers like estrogen and progesterone receptor, human epidermal growth factor receptor 2 status. However, there is a risk of over-treating breast cancer patients if treatment is solely based on these clinico-pathological features. So what is the purpose of this genomic assay? It is a predictive and prognostic tool. So its purpose is to estimate the disease recurrence and to predict reduction in risk of recurrence with adjuvant systemic treatment. And hence it prevents over-treatment of the breast cancer patients. The list of genomic assays, the most widely used ones are: number one, the Oncotype DX 21 gene recurrence score; second, MammaPrint; third, EndoPredict; fourth, Prosigna; and fifth, breast cancer index. Oncotype DX, it is based on RT-PCR technique. The biological material used is formalin fixed paraffin embedded biopsy sample. It measures the expression of 21 genes, 16 cancer-related genes, and 5 reference genes that serve as internal controls. The cancer-related genes include estrogen group gene, HER2 group gene, proliferation genes, and invasion group genes. The recurrence score range from 0 to 100. It is one of the most validated assays. It predicts the risk of recurrence and how likely a patient is to benefit from chemotherapy treatment after surgery in early stage breast cancer patients. Oncotype DX has demonstrated benefit from adjuvant chemotherapy primarily in patients with high recurrence score. RX Ponder trial. It was a prospective trial which evaluated the recurrence scores, prognostic, and predictive value among women with ER positive, HER2 negative, 1 to 3 axillary lymph node positive breast cancer with recurrence score of 25 or lower. The trial demonstrated no additional benefit of adjuvant chemotherapy to 5 years disease-free survival in post-menopausal women with a recurrence score of 25 or lower, regardless of the number of nodes, the degree of nodal involvement, or the range of recurrence score. The 5-year disease-free survival was 91.9% among endocrine therapy alone versus 91.3% among the chemoendocrine group. According to ASCO guideline 2022 for Oncotype DX, the recurrence score should be offered to guide decisions regarding adjuvant endocrine and chemotherapy among postmenopausal women with 1 to 3 node positive, ER positive, HER2 negative early breast cancer patients. Chemoendocrine therapy should be offered to patients with RS score of more than equal to 26. Recurrence score should not be used to guide systemic chemotherapy decisions among premenopausal women with 1 to 3 node positive, ER positive, HER2 negative breast cancer. Currently, there is insufficient evidence for use of recurrence score among patients with more than equal to 4 nodes involved. Second is the Mama Print assay. It is a microarray based tool. Fresh tissue or FFPE sample can be used. It uses 70 gene expression to assess the prognosis of breast tumor. The biological functions of the 70 genes are regulating cell cycle, invasion, metastasis, proliferation, survival in circulation, extravasation, adaptation to the microenvironment, as well as angiogenesis. It is an approved test by US FDA for breast cancer patients more than 61 years of age with stage 1 or 2 lymph node negative or 1 to 3 lymph node positive disease. MINDAC trial is one of the most prominent landmark prognostic trials that evaluated the value of a 70 gene assay. Patients in this trial, patients were divided into 4 groups based on their clinical and genomic risk. Number 1 group was both high clinical and high genomic risk women. In this group, chemotherapy was given in this trial. Second group is both low clinical and low genomic risk women. Chemotherapy was omitted in this group. Third group is low clinical risk and high genomic risk women. Mama print was not found to be useful in this group, and the data is insufficient to recommend the use of mama print in this group. Number 4 is high clinical risk and low genomic risk group of women. The mama print is useful in this group. In the group of high clinical risk and low genomic risk, where the patients were ER positive, HER2 negative, and 0 to 3 nodes were positive early breast cancer. The long-term follow-up data of this study in this group was reassessed on the basis of age of the patients, and 2 groups were made. In the age group of 50 years or less, the 8-year distance metastasis-free survival was 93.6% with chemotherapy and 88.6% without chemotherapy. Hence, it shows that adjuvant chemotherapy was beneficial, and mama print therapy is not recommended in this group. And the other group was age more than 50 years. In this group, the 8-year distance metastasis-free survival was approximately 90% with or without the chemotherapy. Hence, there was no benefit of chemotherapy in this group, and the mama print tool is recommended in this age group. According to ASCO guideline, mama print is recommended to guide adjuvant endocrine and chemotherapy decision among patients older than 50 with high clinical risk, node negative or 1 to 3 node positive breast cancer. Mama print test is not recommended to guide adjuvant treatment among women aged 50 or younger with high clinical risk, node negative or 1 to 3 node positive breast cancer. The evidence for clinical utility of the mama print test is insufficient for use among women with low clinical risk breast cancer regardless of age or menopause status. Currently, there is insufficient evidence for the use of mama print among patients with more than equal to 4 nodes involved. Third is the Prosigna or PAM50 genomic assay. It measures the expression of 50 genes. It provides a risk of recurrence score that classifies patients into high, medium, and low risk recurrent classes. Validation for PAM50 came from the ABCSG8 trial. It is useful for predicting the risk of distance recurrence in postmenopausal women with ER-positive early breast cancer treated with adjuvant hormonal therapy. The probability of 10-year distance-free relapse-free survival based on the ROR score cohort was 96.7% in the low-risk cohort, 91.3% in the intermediate, and 79.9% in the high-risk cohort. These results were seen regardless of whether the pathologic node involvement was present. It is not predictive of benefits from treatments such as length of adjuvant endocrine therapy or the need for adjuvant chemotherapy. No patient received adjuvant chemotherapy in the ABCSG8 trial. In addition, further analysis of women randomized to radiotherapy or control after breast conservation surgery also did not show predictive benefit of PAM50 testing for benefit of adjuvant radiation. According to ASCO guideline 2022, evidence is inconclusive to recommend using the Prosigna test to guide decisions for adjuvant endocrine and chemotherapy among postmenopausal women with 1 to 3 node positive breast cancer. Regardless of nodal status, the Prosigna test is not recommended to guide decisions for adjuvant systemic chemotherapy among premenopausal women with breast cancer. There is currently insufficient evidence for the use of Prosigna test for treatment guidance among patients with more than or equal to 4 node positive breast cancers. EndoPredict. It is a RNA-based molecular test. It studies 8 cancer-related and 3 reference genes to predict distance recurrence in ER-positive, HER2-negative breast cancer patients. It was evaluated in 2 large randomized phase 3 trials, ABCSG 6 and 8. Cohorts were treated with endocrine therapy only. Study combined EP with clinical characteristics of nodal status and tumor size to generate a hybrid score named EP-CLIN to improve the prognostication. Patients were classified into low-risk group with EP-CLIN score less than 3.3 and high-risk group with EP-CLIN score more than or equal to 3.3. Results showed significantly different 10-year rates of distant recurrence rates between low-risk group versus high-risk group. 4% in the low-risk group and versus 22 to 28% in the high-risk group, and outperforming the conventional clinico-pathological parameters. EP and EP-CLIN prognostic value for predicting disease recurrence has also been validated among ER-positive, HER2-negative node positive breast cancer patients who received chemotherapy in addition to endocrine therapy in phase 3 JCAM 9906 trials. Rate of 10 years of metastasis-free survival in low-risk EP score group was 93% versus 70% in the high-risk EP score group, and 100% for low-risk EP-CLIN score group versus 72% in the high-risk EP-CLIN score group. According to ASCO guideline, EndoPredict can be used to guide decisions for adjuvant endocrine and chemotherapy among postmenopausal women with breast cancer that is node negative or 1 to 3 node positive. It is not recommended among premenopausal women with node negative or node positive breast cancer. Currently, there is insufficient evidence for the use of EndoPredict tests for treatment guidance among patients with more than or equal to 4 nodes involved. Breast Cancer Index, it analyzes the expression of 7 genes and classifies breast cancer patients into low risk and high risk groups. A study by Zhang et al. Showed significantly lower rate of distant recurrence among low risk groups, 15-year risk of distant recurrence of 1.3% among low risk group versus 29% among high risk group. It is predictive. The predictive component of breast cancer index to assess benefit from extended endocrine therapy has been validated in multiple studies. MS17 trial, it was a prospective randomized phase 3 trial. It evaluated the role of letrozole as extended adjuvant therapy among postmenopausal women with ER-positive breast cancer that completed standard 5 years of adjuvant tamoxifen and remained disease-free. Study shows that BCI genomic testing was successfully able to identify patients who have benefited from extended endocrine therapy. Patients with high BCI had a 5 years recurrence-free survival of 73% among the placebo group versus 89.5% among the extended endocrine therapy with the letrozole group. Absolute risk reduction of 16.5%. However, patients with low BCI did not have a significant reduction in their 5 years recurrence-free survival. Transatom trial. High BCI patient also derived benefits from 10 years versus 5 years of adjuvant tamoxifen. And the low BCI patients did not have significant benefits from the extended endocrine therapy. According to ASCO guidelines, BCI tests can be offered to guide decisions about extended endocrine therapy among patients with node negative or 1 to 3 node positive breast cancer who have been treated with 5 years of primary endocrine therapy without evidence of recurrence. Currently, there is insufficient evidence for the use of BCI among patients with more than equal to 4 nodes involved. To summarize, Oncotype DX studies 21 genes, and it was studied in SWOG and RxPonder trials. And according to ASCO guideline, in post-menopausal women with 1 to 3 node positive, ER positive, HER2 negative patients, it should be used to guide systemic endocrine and chemotherapy decisions. And in premenopausal group, it is not recommended. The Mama Print assay studies 70 gene, and it was studied in MINDAC trial. And in the postmenopausal group, it should be offered to guide adjuvant endocrine and chemotherapy decision among patients older than 50 years with high clinical risk. And in patients with 50 years or younger, it is not recommended. And third is Prosigna. It studies 50 genes, and it was studied in ATAC and ABCSG trials. And the data about is inconclusive to be recommended. And in the premenopausal group, it is not recommended. EndoPredict, it studies 8 genes. It was studied in ABCSG and 6 and 8 trials. It can be used to decide adjuvant endocrine therapy or chemotherapy in the postmenopausal group. And in the premenopausal group, it is not recommended. The breast cancer index, it studies the 7 genes. It's studied in MA17 trial and Transatom trial. It can be offered only regarding extended endocrine therapy among patients with node negative or 1 to 3 node positive breast cancer who have been treated with 5 years of primary endocrine therapy without evidence of any recurrence. This is a table which shows that in the patients with ER positive, HER2 negative group, if the patient is node negative, then in premenopausal group or with patients age less than equal to 50 years, Oncotype DX has a high evidence of quality and a strong recommendation for utility in clinical practice. And in the postmenopausal group or patient with age of 50 years or more, Oncotype DX and Mama Print have a strong recommendation along with EndoPredict, Prosigna, and BCI, which have moderate strength of recommendation. KI67 and ISC4 can be used instead of these genomic assays where the availability of genomic assays are an issue. And in the group of patients with 1 to 3 positive node, in the premenopausal group, there is insufficient evidence to recommend a biomarker for use. But in the postmenopausal group, the Oncotype DX and the Mama Print have a strong recommendation, and along with EndoPredict and BCI having moderate strength of recommendation. The Prosigna is not recommended in this postmenopausal group in 1 to 3 positive nodes group of patients. For patients with more than equal to 4 positive nodes, there is insufficient evidence to recommend a biomarker. And in patients with HER2 positive, be it ER positive or ER negative and HER2 negative group, there is no mature evidence to recommend use of any of the biomarkers described here. This is an algorithm on the biomarker to guide decision on the adjuvant systemic therapies. So if the woman with early stage invasive breast cancer, first we have to see the HER2 receptor status. If it is positive, there is no biomarker as of now that can be used. And if the patient is HER2 negative, then we have to see for the estrogen receptor. If the estrogen receptor is negative, the these genomic assays are not useful. If the patient is estrogen receptor positive, then we have to see if the patient is premenopausal or postmenopausal. If the patient is premenopausal or age is less than equal to 50 and the node is negative, then oncotype DX is strongly recommended. But if the node is positive, then there is insufficient evidence to recommend a biomarker. And if the patient is postmenopausal or age is more than 50 years and the node is negative, oncotype DX is strongly recommended. Mama print is also recommended with moderate level of evidence. Endopredict, Prosigna, and BCI can also be used. But if
Dr.
the
Krishna, please wind down.
yes, ma'am. And in the node positive group, if it is 1 to 3 node positive, then oncotype DX, Mama print, Endopredict, and BCI can be used. Prosigna is not recommended. So the take-home message is oncotype DX, Mama print, BCI, and Endopredict may be used to guide adjuvant endocrine and chemotherapy in postmenopausal or age more than 50 years with ER positive, HER2 negative, node negative, or 1 to 3 node positive early breast cancer. Prosigna and BCI may be used in postmenopausal patients with node negative, ER negative, HER2 negative, ER positive, HER2 negative breast cancer. In premenopausal group with node negative, ER positive, and HER2 negative breast cancer, oncotype may be used. In premenopausal patients with 1 to 3 node positive, benefit from chemotherapy is present regardless of the genomic assay result. BCI may be offered to patients with 0 to 3 lymph node positive who received 5 years of endocrine therapy without recurrence to guide and extended endocrine therapy. Ka67 or IHC4 may be used in postmenopausal women when genomic assay are not available. For patients with 4 or more lymph node positive, no data is available. And in HER2 positive and TNBCs, triple negative breast cancer, none of the assays are recommended. Thank you. Thank you for a kind attention.
Wonderful and very knowledgeable presentation, Dr. Krishna. I would request our mentors to take proceeding of question answer session with kind remarks.
Good evening, everyone. Yeah, a very wonderful presentation, and Dr. Krishna has covered all these genomic assays in detail. I'm Dr. Shaina, a medical oncologist from Medanta. So I think among all the assays which have been covered, the questions are coming on can assist, scan script, and all this. So in clinical practice, we are not using it. Still, we do still go for the oncotype DX, the validated, globally validated assays. And the most commonly that we use is oncotype DX. So what I would like to ask first, Dr. Krishna, what is your clinical practice? How often and which are the patients do you offer these assays in your clinical practice?
Mostly the oncotype DX is the most validated tool. So it is the most widely used assay. And we use it mostly in patients with ER positive and HER2 negative status with 1 to 3 node positive or the node negative status of the patients, and in the mostly in the postmenopausal group.
Not in the premenopausal patients?
No, ma'am.
Okay. So like in every field of oncology, now the things are moving towards more precision medicine and trying to de-escalate treatment for our breast cancer patients and try to reduce the chemotherapy toxicity for as many patients as we can. So these early breast cancer patients, we offer for all the postmenopausal patients like discussed, N0 and N123. Even the premenopausal patients with an early breast cancer with a node negative N0 disease, we do offer oncotype DX wherever possible, because we have seen some patients having a low recurrence score assay and being able to avoid chemotherapy in these patients. However, we try to be more careful when the age group is less than 40 years. Dr. Devrat sir, if you have any further things.
Yeah, so thank you very much for the comments, and thank you, Dr. Krishna. It was an excellent presentation. I guess Canesis is something that we'll keep on coming back to, and I personally feel that although it's an IHC-based test, we are awaiting more robust data. I think the advantage of that test potentially is the fact that a lot of those patients are Indian patients and therefore Indian biology. And I think cost is certainly a concern. So for a lot of us who practice in the well-off urban centers, de-escalation is possible because these patients are able to afford the costlier gene expression profiling. But for a significant number of our patients who may not be able to afford that expensive a test, CANSS potentially offers option of de-escalation if the test is low. I guess all of us are awaiting more data. There's this interesting question about hormone therapy, and Dr. Charu has asked this, and are there any circumstances where we use genomic tests for endocrine therapy in HR positive? Any thoughts on that, Dr. Krishna?
Yes, sir. If we want to extend the endocrine therapy, there are genomic assays which can predict if we can. Yes.
You would want to. So I agree. I think taking it forward, again, gene expression profiling help us understand the overall risk of recurrence, and we also understand that the extended hormone therapy would perhaps actually be able to offer greater advantage to women who are actually high risk. And therefore, what I do in my clinical practice, and this is something that's also there in the ASCO guidelines, is that if you have a gene expression profiling risk which is low, you can actually think of shorter duration, that's 5 years instead of the extended hormone therapy for these patients. So is Dr. Atul, are you here? Do you have any?
Yeah, I'm here.
Yeah, please go
ahead. So basically, we have been using it. I think the least common users of Oncotype DX would be us. So I feel that node negative patient, we have had enough. One, cost is a big issue in our center, and any public center, there would be a funding issue. So we've had enough experience with, I think, clinical modeling and use of clinical markers that have been there for almost decades. And we have learned how age is a big factor, how PR positivity or negativity, the good old grade, and in node negative patients. So if all the things are going towards one direction, I don't have any confusion in not using chemotherapy, avoiding chemotherapy. So if the size is 1.52 centimeter and then PR all 8x8, and you see a grade 1 or 2 tumor and a 60-year-old lady, and you also see on top of that Ki67 is 3 to 5%, we can argue on reliability. But these are kind of patients where I wouldn't much be inclined on kind of getting these tests done. I'm more interested in this 1 to 3 lymph node or patients who have mixed kind of markers. So on one side, it's a grade 3 tumor, but still a smaller tumor in an elderly. Yes, it definitely helps me taking a decision, of course, if the patient can afford. But most of the times you're again stuck when you get a score of, say, 24. Like 25 is the cutoff and you are stuck at 24. What do you tell your patient? Like, I am not really confident at the score of avoiding. So, it's very difficult at times, but then you have to follow whatever has been used in the study. We use a 25, but I would be nervous at 24 again with kind of limited. And on the other hand, if you have a patient who's a 35-year-old lady with a 4-centimeter tumor with grade 3, again, there's limited utility of these genomic scores. So I think it is kind of rational use of genomic scores that would be very, very important till the cost comes down, till everyone can do these tests. Till then, I think this justified use of these tests can definitely be helpful in the clinics, especially in resource constrained settings like ours.
I think the other aspect is the premenopausal subset, and especially the younger women, where the binary score may be lower, but you really need to look at the clinical risk and look at the size of the tumor, the grade of the tumor, and therefore it's not below 26. It's actually anywhere between 15 to 25, where the patient may still be a candidate for
age,
adjuvant.
according to the age.
Yeah, if she's less than 50. So I think that's one important
So it
point.
would
that
be
we must
difficult at score of, again, say 15 in a premenopausal woman, whom you have a 35-year-old lady with you, and then you have a 4 to 5 centimeter large tumor with a grade 3, and you get a score of say 14, 15. I would be very nervous avoiding chemotherapy here, despite whatever the risk profiling gives me. So these are there to assist us, but sometimes we land up in more confusion than not. So I think it's very important where we use and how we use these tests are very, very important. And before getting the results, the implications are discussed with the patients first of all.
Okay.
I think the other question that's there in the chat box is about key 67. So I think it's Dr. Charu who's asking us if, in the absence of genomic profiling, how much significance would you pay to key 67 in your treatment? Dr. Shaina, would you take this one?
Yeah,
Interesting one.
so generally what we do is Ki67 can be very subjective depending upon the lab that it is being done at. So what they say is usually if it is less than 5% or 10%, we are okay to, and it's a ER/PR rich tumor with an older patient, we sort of take it to be a lower risk disease. Or if we have a Ki67 of more than 30% is what we would call a true high Ki67. Between that, it's always very difficult to decide. So like Dr. Atul sir mentioned, and this, other than the Ki67, looking at grade, the size of the tumor in patients where the borderline score is there, and in patients who probably cannot afford an oncotype DX, but the older ones we want to take a decision on probably trying to use only endocrine. So there, one of the rule which is mentioned is a rule of 4. Like 1 centimeter tumor with a grade 3, or a 2 centimeter tumor with a grade 2, or a 3 centimeter tumor with grade 1. So if it matches that 4 score, then you take it as a high risk, other ones are low risk. So just roughly in my clinical practice, I do look at these things and then correlate Ki67. Mostly the cutoff taken as 10% and more than 30%, and in between that, it's always a little confusing.
I think that's a good point. All of us get a little confused with Ki67, and I'm sure all of us have had patients where the same sample has been, identified to have different Ki67 values even in the same hospital. So I guess I agree. I agree with Dr. Shaina, and I also agree with Dr. Atul that it's a multitude of markers in which Ki67 is one, and it's very rarely that I, as a clinician, or as I understand Dr. Shaina or Dr. Atul, as clinician, would use just a Ki67 value to guide our adjuvant treatment options.
Would request everyone to mute except the speakers.
Can organizers do that? Is there control from that side?
Yes, I'm taking care of it. Yes, I'm doing it.
Please, because there is a lot of disturbances.
Yes, absolutely.
So any other questions, Dr. Charu?
One small thing I would, sorry, ma'am, please.
Yeah, please, Dr. Shaina.
No, please go ahead, Shaina.
Okay, just one point I would like to bring out here is that most of these studies in younger age, they did not have a lot of patients, the RX responder study or the other, where many patients receive ovarian suppression. So in younger patients, that is another thing which would, I think, come forward and de-escalate treatment in terms of using dual hormone therapy versus chemotherapy at a later point when we have more data. So that is another thing to bring out to the residents, that most of these study RX responder, most of the patients, only around, I think, less than 10% actually had ovarian suppression. So now we know from the soft and text trial the benefit of using ovarian suppression. So the benefit of chemo could have been actually because of the ovarian suppression caused by chemotherapy rather than by chemotherapy itself. So we need more data on that, which would come out, I think, in the future, and we would de-escalate treatment for a larger number of patients is what I feel.
Agreed.
Sir, anything from your side?
No, absolutely. I fully agree with you. I think this is a question that we need more answers to. And I guess guess probably that's one way of de-escalating. Instead of offering chemo, you offer OFS. But I think we'll need more data before we start doing that.
Great. Thank you. Thank you so much, all the mentors. And if there are no more questions, I think, Garima, please invite the third speaker.
Okay, ma'am.
Thank you.
Dr. Arka, please share your PPTs.
I think you're already running behind the schedule.
Ma'am, is my screen visible now?
Yeah,
Yes.
screen is visible. Sir.
Thank you, ma'am.
Yeah, your PPTs are visible.
Am I audible, ma'am?
Yes.
Okay.
Dr. Arka, kindly present this in presentation mode.
Ma'am, actually,
Yes,
I'm
screen
not.
right.
Actually, it's opened in other computer.
Okay.
It's okay, Dr. Sinha, please start your presentation.
Okay, the topic of today's presentation is overview of nodal irradiation in early breast cancer. I'm Dr. Orkuprava Sinha, is our radiation oncology from AIIMS Kalyani. Now, the topic of today's discussion, the contents will be lymphatic drainage, patterns of nodal failures in breast cancer management, why to treat nodal stations, how nodal stations are addressed, nodal treatment of clinically negative and positive axilla, role of regional nodal irradiation after neoadjuvant chemotherapy, indications of each nodal stations, and future directions. Ma'am, kindly full screen my screen, please. The third PPT, ma'am, third slide. So question comes, what is early breast cancer? According to National Cancer Institute data, breast cancer that has not spread beyond the breast or the axillary lymph nodes, that includes ductal carcinoma in situ stage 1, 2A, 2B, and 3A breast cancers. So the lymphatic drainage pattern of breast over the axilla, supra and infraclavicular region, and internal mammary region has already been discussed in our previous class. So the Annals of Surgery paper, it's 5. From the Annals of Surgery paper, we can see that the axillary lymph nodal spread is maximum from any quadrant of the breast. So the risk of subclinical microscopic disease is dependent on not only the tumor size, but also the invasiveness of the tumor and many other factors. And thereafter, the extent of surgical staging or evaluation of axilla is also important for this. The patterns of failure are also dependent on lymphatic drainage of the breast that has been already discussed, and failure of and recurrence patterns in node positive and node negative patients are a little bit different. Next. So factors modifying the axillary spread are dependent on multiple factors. They are the tumor size, grade, age, and the LVI. So the palpable and non-palpable lesions all have shown higher propensity to go to the axilla. Wood et al. Trial, Mustafa et al. Trial, Gan et al. NSABP04 all have proven that tumor size, grade, age, and LVI all are the predictive factors. Next, please. Next. Coming to factors modifying the IMN spread, it has been seen that when the lower inner quadrant is involved, along with presence of axillary lymph node involvement, there is maximum chance of IMN involvement, internal mammary nodal irradiation, nodal spread. So Veronesi et al. Trial, Sug et al. Trial has shown us that risk factors like tumor more than 2 centimeter, having a premenopausal lady with axillary lymph node positivity have higher chance of internal mammary nodal spread. Next. So on GIST, tumor size, location, number of axillary lymph nodes are the important factors. Next. Along with that, factors modifying the supraclavicular spread will be dependent on other factors. Next, please. So there are factors like number and site of axillary lymph nodes and tuber size, like that of a tumor of more than 5 centimeter of size and site over there having then level 3 axillary lymph node will have higher propensity towards supraclavicular spread. Next, please. So why to treat the nodal stations? Next, please. The question comes because it has been shown that previously all the patients were treated with either axillary nodal dissection or with axillary nodal RT. Next, please. So this bar diagram shows us that with increasing in tumor size of more than 5 centimeter and having more than 4 lymph nodes, the chance of 5-year survival rate gradually decreases. Next, please. So why not to treat all patients with axillary lymph nodal dissection or axillary RT? This is because the chance of lymphedema, pain, decreased mobility, all this. Next, please. Monsell et al. Trials showing swelling, weakness, restricted mobility, stiffness, pain, and numbness in patients who are undergoing axillary surgery. Next, please. Whereas in Clark et al. Trial, breast edema was visible in 20% and after breast surgery, and in 80% if axillary lymph nodal dissection is done. So it is quite evident that all patients must undergo an identification to either undergo an axillary treatment or to be omitted or not. Next slide, please. So how to address these nodal areas depends on either loco-regional treatment or the systemic therapies. Radiotherapy, surgery, sentinel lymph node biopsy are the loco-regional treatment, whereas the chemotherapy, hormonal therapies are the systemic therapies that have an effect over the microscopic disease of the axilla. Next slide, please. So coming to the next main important part, that is clinically node negative axilla, where the role of sentinel lymph node biopsy. Coming to ACOSOT Z0011 trial, next slide. It has already been described that, next please, that in T1, T2, N0 tumors undergoing breast conserving surgery having 1 to 2 sentinel lymph node positivity randomized into 2 arms, either axillary lymph node dissection or no further axillary treatment, and thereafter undergoing whole breast irradiation and adjuvant systemic therapy, followed by the patient underwent follow-up for 10 years. Next slide, please. So, after a period of 10 years, the loco-regional cumulative incidence between these 2 arms were more or less similar. Not only that, next please, it was also seen that the axillary recurrence, in-breast tumor recurrence, disease-free survival, overall survival were more or less similar in these 2 arms. Next slide, please. More or less similar trial was the IBCSG trial, which considered micrometastatic disease instead of macrometastatic disease. And with T1, T2, N0 disease, it was seen that disease-free survival and overall survival were more or less similar in these 2 arms. So the only difference was they considered micrometastatic disease. So next please. So to conclude from these 2 trials, axillary dissection could be avoided in patients with early breast cancer and limited sentinel lymph node involvement, thus eliminating complications of axillary surgery with no adverse effects on survival. Next, please. But these 2 studies were not out of fallacies. Next, please. So the American Society of breast surgeons have guided us to T1, T2 tumors and having sentinel lymph node positivity with 1 or 2 with acceptance of either whole breast irradiation along with adjuvant therapy in form of hormonal or chemotactic therapy can have an omission of further axillary lymph node according to the ACOSOT Z001 criteria. But due to this small subgroup, they never included T3 tumors having more than 2 positive nodes undergoing mastectomy or axillary axial APBI. Next slide, please. So the fallacies are, there was a very small patient subgroup and the radiation field was large with 2 tangential fields which subsequently incorporated the axilla along with the whole breast or the chest wall. The chemotherapy versus chest wall irradiation standardization was never done because the micrometastatic disappearance was due to chemotherapy or due to chest wall irradiation along with axilla irradiation was never clear. and there was low accrual as the postulated sample size was more than 1,000, but it was something like 400 patients in these trials. Next slide, please. So there was always a consensus that if we can go for no treatment, we can go for radiation in place of no treatment. So in Amaros trial, taking into account T1, T2, and 0 tumors, what they did is they randomized into two arms. Next slide, please. They randomized into two arms in after sentinel lymph node biopsy positivity in axillary lymph node dissection or axillary radiotherapy. 5-year axillary recurrence, recurrence-free survival, DFS, OS, and multiple complications were please. So we can see that disease-free survival and overall survival were again more or less similar in between the two arms. Next, please. Another important thing was with axillary lymph nodal dissection, the chance of lymphedema was found to be 23%, but with RT alone, it was found to be 11%. It is to be noted that that 11% is also incorporated with sentinel lymph node biopsy because all patients undergoing radiation to the axilla were also undergoing sentinel lymph node biopsy. Next slide, please. So to conclude from these trials, they have comparable disease control with axillary lymph node dissection or axillary radiation with lesser morbidity in the RT arm. Next, please. The similar trial was again OTASO trial, which again considered axillary lymph node dissection versus RNI. Overall survival and DFS were more or less similar, and the 10-year follow-up result came out in 2017 that also showed us that there is no difference in axillary recurrence between these two trials. Next slide, please. So next slide, please. So what if the sentinel lymph node biopsy is negative? So according to the European guidelines like ESMO guideline, if SLNB is negative, there is nothing to do in this subgroup of patients. We can easily omit the patient from treating the nodal regions. But the NCCN guidelines are a little bit skeptical. So this trial from Jaxi et al. Considered four criteria. Please, next slide. They were the margin more than 2 millimeter, menopausal status having premenopausal status, LVI positivity, and size more than 2 centimeter were the four criteria. And it was seen that with 3 or 4 number of risk factors, the chance of locoregional recurrence were 40%. So NCCN was a little bit skeptical towards omitting radiation. Rather, they were in favor of giving radiation if 3 or 4 risk factors were present. Next slide, please. But there was difference in ESMO. This is because if we see this locoregional recurrence, the chestual locoregional recurrence was 28% isolated and 37% total, whereas axilla, supraclavicular, and internal mammary nodal region, the locoregional recurrence was significantly lower. So there is always a gray area. There is always a difference between consensus of NCCN guideline and ESMO guideline or American and European guideline. Next slide, please. So to summarize the management of clinically node negative axilla, if it is SLNB positive, matching with ACOSOG Z11 trial, there is no nodal treatment to be done, but again with high caution, as we have already said, there are multiple fallacies. So it is again an institutional variation. Not matching that criteria, again axillary lymph nodal dissection or axillary radiotherapy is preferred. In this case, probably axillary lymph nodal dissection will have a higher hand. If SLNB is negative with no high risk features, there is no doubt there is no nodal treatment is required. But presence of high risk features or 3 or 4, next please, like those risk factors that has already been discussed, this is always a gray area. And if sentinel lymph node biopsy is not identified, in that case, ALND level 1 and 2 is recommended. Next please. Now coming to the node positive axilla, one of the most important trials was EBCTCG meta-analysis. Next, please. So this was the largest randomized control trial having 10,000 patients in this group. But this study, although they showed us there is advantage with regional nodal irradiation compared to omitting regional nodal irradiation, but it is quite evident that these trials showed us that they could not specify that what are the lymph nodal groups that are to be irradiated. That is, the indications of lymph nodal irradiation could not be ever specified by this trial. Next, please. The more important trial was the MA20 trial, where they considered either high-risk node-negative patients or node-positive patients, and a median of 12 axillary nodes were removed. So out of these patients, 85 patients had 1 to 3 lymph node positivity, 10% were lymph node negative, and 5% have more than 4 lymph node positivity. Next, please. So the result of MA20 trial showed us that the loco-regional recurrence was significantly better in the WBI plus RNI arm, favoring it and having a risk reduction of absolute risk reduction of 2%. There was improvement in 5-year disease-free survival, and also there was better loco-regional disease-free survival compared to the WBI only arm. Next, please. So it came out with a cost of some complications, as it also showed that WBI plus regional nodal irradiation had an increased significant chance of pneumonitis along with lymphedema for these patients. Next, please. Next was URTC trial, where they considered internal mammary and medial supraclavicular irradiation in breast cancer patients. Next, please. And in this trial, again, it was more or less similar, having the, yes, ma'am. Having whole breast. URTC trial, it was having whole breast irradiation versus, and it also included pathologically lymph node N1A or N2A diseases, that is 1 to 3 or 4 to 9 axillary lymph nodes. Next, please. So the result of URTC, next slide. Result of axillary URTC trial also showed us that there is better original in the WBI plus RNI arm, and also the regional loco-regional recurrence in axillary and internal mammary was significantly better in the RNI arm. Next, please. But it is to be noted that MA20, which considered only BCS patients, and URTC, which considered only BCS plus RT patients, if we see the absolute risk reduction in all these areas, it was not very much high. That is, it was all these regional, internal mammary nodal, supraclavicular, axilla, all these lymph nodal areas had less than 2% of nodal risks. Absolute risk reduction. Next, please. So the main drawback with these trials were all nodal stations were always irradiated. That means they never said that when to supraclavicular to be irradiated, when axillary to be irradiated. Rather, RNI arm, all patients were irradiated in all 3 lymph nodal regions. Next, please. Another important trial was DBCG consensus trial, where previously for more than 4 lymph nodes, there is an advantage of RNI has been proven, and there is always a category 1 evidence, but they also tried to find if there is any evidence with 1 to 3 lymph nodes or not. So next, please. So in the DBCG trial, again, they took those patients. Again, it was an old trial, took older chemotherapies. Next, please. They took both premenopausal and postmenopausal patients, and it found that the loco-regional recurrence, there was significant absolute risk reduction with 4 positive nodes, but also in 1 to 3 positive nodes, there was again good absolute risk reduction. So the 4+ nodes became in category 1 evidence, whereas with 1 to 3 positive nodes became in category 2B evidence. Next, please. So to sum up the management of node positive axilla, if there is more than 4 lymph node positivity, there is category 1 evidence of regional nodal irradiation. If 1 to 3 lymph node positivity, there is category 2B evidence of RNI. But if 0 lymph node positivity, according to ESMO guideline, again, there is no significant role of regional nodal irradiation, only chest wall to be irradiated. But if we consider the NCCN guideline, again, tumor size, margin, premenopausal status, LVI come into consideration, and to consider the risk factors, we need to either treat the axilla or leave it, depending on institutional variation. Next, please. Now comes into play, next please, the neoadjuvant chemotherapy. So whatever we have discussed till now, it is for upfront surgery. Now for neoadjuvant chemotherapy, next slide please. It has already been discussed in our previous lecture. Next slide please. Now I am directly quoting from the Selden and Lee paper that randomized trials have demonstrated improved disease-free survival after adjuvant RNI. However, there are no randomized trials currently available that clarify the role of RNI following NSC. Next, please. So it was seen that neoadjuvant chemotherapy has been associated with pathological complete response in axillary lymph nodes in 40 to 75% of patients. And false negative rates of SLNB is always a concern, and that has been thoroughly described in our previous class. Next, please. So there has been multiple trials like Sentina trial, Alliance trial, and many other trials on this purpose. And they have come to a common conclusion, and that has NCCN given us, next please, that in patients This can be improved by removing more than 2 sentinel lymph nodes, as it has been said, at least 3 lymph nodes preferably, using dual tracers, and make marking biopsied lymph nodes to document their removal. Next, please. So although we don't have a very good consensus to how post-neoadjuvant chemotherapy radiation is to be incorporated, next please, we can say that those patients who are having no palpable axillary lymph node and having a clinically N0 disease, the patient will undergo, if the patient is planned for neoadjuvant chemotherapy, next please. After, next please, post-neoadjuvant chemotherapy, the patients undergo sentinel lymph node biopsy. If the sentinel lymph node biopsy cannot be done or the lymph node cannot be identified, we'll have to go for axillary lymph node dissection at least up to level 2. And if the disease is identified, then we'll have to go for nodal RT. And if it's not identified, it's no nodal RT. Again, this is institutional variation will be there. But if SLNB is done and there is identified SLN, in those cases, if it is identified, then ALND followed by nodal RT is recommended. And if it's not identified, then no further axillary treatment is recommended. Next, please. But when there is positive, sorry, the screen is, the slide is so small. So in positive biopsy, clinically N1 and for clinically N2 and N3 diseases, we can say for clinically N2 and N3, there is no variation or there is no confusion that clinically N2 and N3 diseases post NSCT, they will have to go ALND followed by nodal RT. But if after it comes at CN1 disease and after neoadjuvant chemotherapy, there is palpable axillary lymph node, then those patients will have axillary lymph nodal dissection. But in case there is no palpable lymph nodes, those patients will again, in some centers, the patients again undergo ultrasonography. And if in that ultrasonography it comes positive, then the patients again undergo axillary lymph nodal dissection followed by RT. But if it comes as negative, so there is no sentinel lymph node biopsy was done. No USG was done. The patients undergo sentinel lymph node biopsy, and if lymph node again is not found, we'll go for ALND followed by RT. And if sentinel lymph node is found, in those cases, if there is no specific residual disease, we will again see the clipped nodes as present. So more or equal to 2 sentinel lymph node removes with or without marked or clipped node, there is no requirement of ALND or RT. One sentinel lymph node removed containing mark or clip, we will go for no axillary lymph node dissection, but with nodal RT. And one sentinel lymph node dissection removed, not containing mark or clip, will go for ALND followed by nodal RT. Next, please. So last but not the least,
Sinha, you will have to quickly wind up.
Okay. Next, please. Which nodal stations to be irradiated? First comes the axillary nodal stations. So it is next, please. So which nodal stations are to be treated is never clear after multiple trials. Next, please. So the thumb rule was that the subclinical next, please. The subclinical disease over the supraclavicular region and the internal memory, and the microscopic disease over the axilla or the residual disease over the axilla are to be treated. Next, please. So if we consider the indications, next, please. First comes for next, please. Next slide, please. Next, please. For axillary radiation, if we see for extracapsular extension, although different trials have not been able to show the benefit of axillary nodal irradiation for extracapsular extension, but there is a gross institutional variability. Next, please. So in most of the centers in India, if there is gross extracapsular extension present, they are considered for axillary radiation. Next, please. So the other indications, next, please. So the other indications for axillary radiation will be sentinel lymph node positivity with no axillary dissection, inadequate axillary dissection, and high risk disease with no axillary dissection. Next, please. For internal mammary nodal, next, please. Next slide, please. For internal mammary nodal irradiation, again, Danish study and Stemmer et al. Study showed overall survival benefit with internal mammary nodal irradiation. But next, please. But all patients are never treated with internal mammary irradiation. Next, please. Next slide, please. Next slide, please, ma'am. Next, please. So all patients are not treated because clinical failure is very rare of less than 1%, though high rate of surgical and pathological studies of 16 to 40%. Next, please. Next, please. Next. So there are multiple problems with internal mammary nodal irradiation. Next, please. So we can say that the indications will be sentinel lymph node positive in IM and chain, sentinel lymph node positive in axilla with drainage to IM on lymphoscintigraphy. Next, please. Although there are gray areas with central or medial lesion with positive axillary nodes with high-risk features, some institutions follow it. Next, please. And imaging positive internal memory chain. Next, please. There is least variation or differences in opinion for supraclavicular irradiation, and indications are clinically N2 and 3 disease, more than 4 lymph node positivity, 1 to 3 positivity, high-risk disease without axillary dissection, and positive sentinel lymph node without axillary dissection. Next, please. So there are the future directions, that is alliance trial and energy oncology group. Next, please. So they will show us there is any difference between T1 to T3 tumors and N1 tumors after sentinel lymph node biopsy positivity post neoadjuvant chemotherapy. Is there any difference between in breast cancer recurrence and other parameters? And similar trial is the NSABP B51 trial. Next, please. So to summarize all these things, I can say that if there is palpable node and non-palpable node, if NSCT is planned, and after sentinel lymph node positivity, there are changes in the treatment, and with positive biopsy, if NSCT is planned, and then reassess after NSCT if the NSCT is planned, and if not, then axillary lymph node followed by regional RT is recommended. Next, please. So, thank you. Next, thank you.
Great presentation, Dr. Arka, on such a controversial topic. I would request our mentor to share their valuable experience on this topic and also take the question from chat box. Dr. Piyusha, Dr. Sweety Gupta, and Dr. Preech.
Very nice presentation, Dr. Prabha. You put lots of efforts. If you see, more the papers, more the confusion. And, there's a lot of variability in treating RNI in different institutions, and even in one institute, people are following different policies in treating RNI. Some ROs are treating axilla, some ROs are not treating axilla in the same patient. I am like we have been seeing this in our PG times. Some professors were putting different fields and some different. So we used to treat according to their policies. So it is very difficult to make a consensus how to treat RNIs. And the second main thing, we should know that a student must learn the anatomy of breast and its lymphatic supply and lymphatic spread, because it is really very much important to learn the pattern of failure. So we should know how to make our policy, because in the future you should take your decision whether this axilla to be treated or not treated, or the SCF should be taken in the field or not. For that, you should learn the anatomy and lymphatic spread to know the pattern of failure. You should predict where this patient can fail in the future, because over-treatment is not as toxic as the recurrence. And as in the Empress trial, they showed that lymphatic edema is much more in the arm, which is treated by radiation and surgery both. But these days, if you put physio-oncotherapy properly from the time of surgery, you can very well, reduce this edema in the arm. So these days, we are not seeing many patients having more edema in the arm like we used to see in our PG time. So I don't think this dissected axilla with the radiation is giving lots of morbidity or toxicity to the patient. So I think we should be very clear in our mind that the over-treatment.
Yes.
Dr. Karwa, yeah, a very nice and comprehensive presentation, and you have done very justified the topic. Okay, so I have two questions to you. Hello, am I audible? Hello.
Ma'am, your volume is very low. You are audible, but we are not able to make out what you are speaking.
Okay, one second. Now is it audible?
It's better, but still not very, very discernible.
Dr. Krava, what is your institution practice?
Ma'am, most of the times we practice for axillary nodal irradiation that if there is a positive extracapsular extension, gross extracapsular extension is present, and if there is a incomplete nodal dissection with a residual disease present over the axilla, then we treat those patients with axillary nodal irradiation. Whereas for
Incomplete
incomplete
dissection?
dissection, yes, ma'am, incomplete dissection, that is less than 10 lymph nodes are dissected. And in those cases, the patients are treated with axillary irradiation. Whereas for internal mammary nodal irradiation, if more than 4 lymph nodes are if more than 4 lymph nodes are positive with a lower inner quadrant or a central disease, in those cases we treat those patients for internal mammary nodal irradiation prophylactically. And for supraclavicular irradiation, any disease which is either T3 or T4 having any node positivity, we treat those patients for supraclavicular irradiation.
Okay, yes, very well said, Dr. Arka. So supraclavicular, we don't have much controversy. Like if the lymph nodes are positive, then definitely, but still you have to be cautious about the hypothyroidism, which you have to follow up, which you have to see during the follow-up, and the acute mucositis, yeah, or esophagitis, you can say, that is also to be taken care of during the radiation. In axillary, yes. Inadequate axillary dissection, I suppose, is the only indication for axillary irradiation. And after complete axillary lymph node dissection, even if there is extracapsular extension, then the risk of axillary recurrence is very low. And what benefit we are adding by giving axillary irradiation is uncertain. Because by treating with dual modality, definitely the morbidity will be higher. In IMN, yes, the institutional, even after having multiple trials, there is no set answer to this question of treating IMN. There is higher institutional variability. And in the central and medial tumors, yes, if the heavy axillary positivity rate is there, then those patients should be considered for IMN irradiation. But I think at our institution, we are selecting those patients who have gross positive disease in the IMN. So those patients who don't have gross disease in the internal memory chain, we don't take them up for internal memory irradiation. You also have to see whether it is left-sided or right-sided and what cardiac dose you are being able to achieve. That is also very important. So Vinita ma'am is also saying that there is no level 1 evidence showing the benefit of prophylactic IMN irradiation. After the publication of these two trials, MA20 and EORTC in 2015, yes, there was an upsurge in the practice of radiation oncologists. They were being given IMN irradiation, but over a period of time, I think this practice has changed. Sweetie ma'am, would you like to add anything?
Can I make a comment?
Sure, sir.
Yeah. So I've been following this discussion since the beginning, and all these discussions about including or excluding such and such levels of axilla are redundant actually if we don't exactly know what are the boundaries of these axillary levels. And if my radiation oncology colleagues really want to understand the concepts which are being discussed in papers and forums like this, they should actually practice drawing the axillary levels, draw the various different axillary levels, 1, 2, 3, draw the supraclavicular level, draw the interpectorals, so that they can understand what these papers and forums are talking about. How is it that some axillary levels do get radiation when we use such technique of radiation? Otherwise, discussing these are very, I mean, all right, it's theoretically it's good, but when we don't exactly know where the radiation is going when we are giving radiation, whether we are including radiation, whether we are including axilla or not, that makes it all very redundant. One can take help of papers like Danish breast group guidelines on this about how to contour axilla. And I request everyone, all of my junior colleagues, this is how I learned, and this is how I keep learning actually. So we should take a patient which has already been treated or about to be treated, and we should draw axillary levels, different axillary levels, each one differently and separately. That is how we'll be able to control and know what we are actually doing.
Yes, I also agree. Level 1 and level 2, they are being irradiated in the tangential fields. And yes, we now have papers which show the incidental radiation to axillary or IMN. Our DNB student has done the thesis also on this topic, the incidental radiation to IMN and axillary lymph nodes when we are not intentionally treating them. So that needs to be taken care of.
When I was doing my PG, that was the era that we, the radiation oncologists, used to say radiation does not cause much complications, not much lymphedema. But now it is the era of de-escalation, not only in radiation, but surgery as well.
Exactly.
And so if we don't know what we're actually doing, it will be very difficult to, control things. So anyways, that was quite good. Shall we begin the next session?
Thank you, Dr. Piyush and Dr. Peshi. Now we are heading towards our next session, that is a panel discussion, consensus and controversy. Moderator of this session is Dr. Namita, Senior Resident Max Super Specialty Hospital, Dr. Pritha, SAR RJCI, Dr. Faraz with us, SR AMU. From surgical side, Dr. Avijit Mondal, AIMS, Rishikesh, Dr. Pratap, AIMS, Delhi, and from medical oncology, Dr. Devesh and Dr. Athira from Max Hospital, Delhi. And our mentors for this session are Dr. Abhishek Gulia, Associate Director, Radiation Oncology, JP Hospital, Noida, Dr. Aditi Chaturvedi, Senior Consultant, Surgical Oncology, Max Saket, and Dr. R.P. Chaudhary, Director and Head Medical Oncology, Metro Hospital, Noida. Dr. Namita?
Yes, ma'am.
Kindly start panel discussion.
Yes, ma'am. Good evening to everyone. I'll be conducting the discussion for the nodal management on controversies over nodal management in early breast cancer. So I present to you a case wherein a 42-year-old married woman, nulliparous, premenopausal, it's not, are my slides not visible?
No, Namita, your slides are not visible.
Just give me a minute. Give me a minute. Are my slides visible now?
Visible.
Yeah.
Okay. Yeah. So a 42-year-old woman presented with a 42-year-old woman, nulliparous, premenopausal. She presented to the OPD with a self-palpated lump in her left breast since 1 month. She had no complaints of pain, discharge, nipple retraction, or any skin changes. Relevant history in this case, she did not have any history of smoking, alcohol. Her mother died of ovarian cancer. Her maternal aunt has breast cancer. To the surgeons, to Dr. Devesh, I would like any other relevant history that you would like to ask. Dr. Devesh. Dr. Abhijit, Dr. Athira.
Hello, am I audible?
Yeah.
I would also like to ask about whether she was taking any hormonal contraceptives or during her time, on what type of they are taking and what's the duration, because that is a known risk factor.
Mm-hmm. Any other history?
As well as whether she had any histories of any biopsies done for any benign breast lump, and if possible, what was the report of evaluation which was done for that lump?
In this
And
patient,
whether she had any history of radiation exposure at a younger age for some other cause, just radiation specifically.
Okay. So would you like to ask any history regarding IVF?
Pardon?
Would you like to ask any history regarding IVF? Since the patient is a nulliparous.
Yes, I would like to know the IVF history also.
Okay, we'll proceed with the case. Her age at Menarche was 12 years. Her menstrual history, she had regular periods for 3 to 4 days every month. She's nulliparous. And on examination, her performance score was 0. And on local examination, there was a 2.5 cross 2 centimeter lump in the upper inner quadrant of left breast, which was mobile, firm in consistency, and the skin was free. The left axilla had no palpable node. Opposite breast and axilla were A and D. Bilateral SCF was clear. Systemic examination was NAD. How would you like to investigate this patient? Dr. Athira?
Hello.
Yeah.
First of all, I would like to do the blood workup for the patient.
Yeah.
In the form of CBC, KFT, LFT, and also the biopsy, triple assessment biopsy,
Okay.
and ultrasound.
Ultrasound
of the breast and the axilla.
Okay.
And also, since she's having a history of maternal aunt being positive and also ovarian history, then we'll also do for a genetic testing for this patient.
Okay, so what are the other indications for BRCA testing?
The indications is if the patient is having a personal history of breast cancer. So the main indication is if the age is less than or equal to 50 years, or if any age, if the patient is having a TNBC, or if there is a multiple primary breast cancer history, and also if there is a male breast cancer history, or ancestry is like Jewish ancestry, and also lobular carcinoma with the personal history of diffuse gastric cancer. And if there is any close blood relatives of any age with breast cancer, history of breast cancer, male breast cancer, prostate cancer, ovarian cancer, all these are indications of BRCA testing as per NCCN.
Okay. So, Dr. Abhijit, what all would you like to, what imaging investigations would you like to do for this patient?
For this patient, I'd like to do as she is a high risk patient and is a 40s. So based on the breast density, either if it's her breast is not that dense, then we can go for a diagnostic mammogram, or else better would be in this scenario, I would go for a MRI for this patient. MRI of the breast, and as well as for the axillary evaluation, if clinically it's a N0, or anyways, I will like to do a axillary lymph node evaluation also by ultrasound.
Okay. So in this patient, we had done a digital mammography in which there was a focal asymmetry of approximately 2.5 centimeter that was seen in the left breast upper inner quadrant, and there was no lymph node seen. It was BI-RADS 4B. Do you think any other investigation? Okay, you've already answered this. So MRI breast sensitivity is 94% and specificity is 74%. But in young patients who have dense breasts, we prefer to do an MRI. But the disadvantage of doing an MRI is that it overestimates the soft tissue of breast, and many patients who could have undergone BCS convert to mastectomies.
Yes, with MRI, we all because there is because of this, often we also need multiple image guided biopsies of the suspicious areas on MRI. That's another problem with MRI in this patient.
Dr. Gulia, would you like to add anything?
Proceed, Dr. Namita.
Yes, ma'am. We did a biopsy for the patient, which came out to be positive for invasive ductal carcinoma, grade 3. She was ER 8/8, PR 8/8, and HER2 was 1+. Should we evaluate the axilla any further? Dr. Pratap?
An ultrasound of axilla to see for any suspicious nodes and sampling if required.
Okay. So we did the ultrasound axilla and it showed a suspicious level 1 node of 11 mm. What next would you do, Dr. Pratap?
If it is ERPR positive, if you are going for upfront surgery, then I would like to do an SLNB along with the primary surgery. We are going for any NACT, then.
No, but the node is clinically negative, and on ultrasound we have found that that there is a suspicious node of 11 mm. So, would you like to do anything else before?
There is availability of FNAC.
So in this patient, we did FNAC from axilla, which was negative. Any role of PET scan in this patient, Dr. Pratap?
As such, in our institute, we don't do PET scanning for early breast cancer. But there are some studies which have shown distant mets in some patients.
Dr. Aditi, would you like to comment on this?
On the use of PET scan in this patient?
Yes, ma'am.
In fact, I agree that if it's an early breast cancer and node negative, she's T2N0, I think PET scan is not mandatory in this patient for sure. So I think on imaging also, you said there was only one node with cortical thickening and the FNA was negative.
Yes, ma'am.
So I think we can avoid a PET scan in this patient. It's only if the patient is very anxious or they're very keen on a PET scan would you do it. It's not routinely recommended.
Okay, ma'am. So in this patient, what surgery would you offer, Dr. Abhijit?
In this patient, I would go for a breast conservation surgery if the patient is willing for it, along with the SLNB.
Okay. So our patient opted for BCS. And how would you manage the axilla, Dr. Abhijit?
In this patient, I will do a SLNB. And after SLNB, if we find there are no nodes, no positive nodes are identified, then patient is fine and patient doesn't require any further axillary lymph node dissection. And 1 to 2 nodes are identified and it meets the criteria as it was previously mentioned by my colleague, the Z11 criteria, T1, T2 clinical N0 and WBRT planned. If all the criteria are met, then also we will not do any further axillary lymph node dissection. And if more than 2 nodes are 3 or more nodes are found positive on SLNB, then I will go for a completion axillary lymph node dissection.
Okay. So in this patient, we did a BCS sentinel lymph node biopsy. The tumor size was 2 into 1.5 centimeter. The margins were negative. The LVI was negative. And on sentinel node biopsy, we found that there was micrometastasis in 1 out of the 4 nodes that were dissected. So our pathological stage became PT2N1 with MI, that is microscopic disease, micromets. So will you now proceed with an ALND?
No, in the presence of only a micrometastasis in 1 node, current evidence suggests that no need for any further ALND in this patient.
Okay. So any role of adjuvant systemic chemotherapy, Dr. Athira?
Yes, there is a role of adjuvant systemic chemotherapy since the patient is 42 years and premenopausal. So there is, according to NCCN and RxPonder trial, there is no FH gene expression assay has no role. So we'll proceed with adjuvant systemic chemotherapy.
Would you like to do any other test?
Actually, since the patient is a premenopausal and node positive, so no need of genetic assay as such.
Okay. Dr. Chaudhary, sir, could you comment on this?
Hi, good evening.
Good evening, sir.
I missed a few initial slides. So whether bone scan was done pre-operatively?
No, sir.
No. Bone scan was not done, right?
No, sir.
I would like to comment from the residents. So the PET CT is definitely not indicated in early breast cancer, specifically T2 lesions.
Yes,
But in hormone positive, sometimes we see in clinical practice, even in the small primaries, we do get the bone mets.
Yes,
So
sir.
definitely one point I would suggest that bone scan should be done. It's available largely at all the centers, and it's cost effective also.
Okay, sir.
And as mentioned by some residents, premenopausal ladies,
Yes.
every patient should be offered chemotherapy without offering any this genomic assays, because they are not validated in this subgroup of patients. One more point about this for the DNB residents, because the clinical practice is guided by not only by the guidelines but also by the patient's preference and where are you practicing. Coming to the previous discussions about the genomic assays, where can assist was there was a discussion on the can assist. So in practice, though Oncotype DX is the most validated test, but we often see the can assist being prescribed by the many physicians. And I think a can assist is one of the most common tests which are being prescribed. And the reason for, because this is there is very good marketing by these peoples, and patient themselves comes to us and with this test, okay, we want to go with this can assist. We can't afford this Oncotype DX. So these residents need to know the exact guidelines apart from the institutional practice.
Thank you, sir. So in this patient, we had done Oncotype DX score that came out to be 30, and we gave adjuvant chemotherapy to this patient. She received 4 cycles of AC followed by 4 cycles of taxane. So adjuvant radiation. So what will be our radiation sites? Dr. Faraz?
Yeah, am I audible?
Yes, sir, you are.
My radiation sites in this case will include the whole breast,
yes, sir,
along with the axilla. I would not like to include supraclav and the IMMs.
Okay.
This is very. I mean, this evening we are just talking about this particular issue only. So whether to go for axillary nodal radiation or not to go for axillary nodal radiation is definitely controversial, but I will go for it because there is no evidence to omit RNI in a micrometastatic disease. The way we have evidence to omit axillary nodal dissection in such cases like IBCSG 2301, we do not have that kind of evidence. So I would like to go for axillary, targeted axillary radiation along with whole breast RT.
Dr. Preetha, your take?
Okay, so as we have discussed before as well, even in the same institute, different radiation oncologists are going to treat it differently. But if we stick to this case where there's BCS has been performed with SLNB and adequate number of lymph nodes were removed for SLNB and just one is positive, that too with just micromets, I would be comfortable just irradiating the breast. But if I want to be a little more cautious, I will agree with Dr. Faraz. I will take the whole breast along with the undissected axilla and then later on followed by the lumpectomy cavity boost. So personally, in my unit, I work with the breast unit, and we would have just gone ahead with the whole breast RT followed by the lumpectomy boost. But I know other radiation oncologists would have taken the undissected axilla as well. So there are studies which obviously do not support the omission of RT, but then there are no studies that indicate that adding the regional nodal irradiation in case of micrometastatic disease, they offer any advantage. So because we don't have any clear-cut advantage of giving RT in micrometastatic disease, so we are just as comfortable with whole breast RT.
Dr. Gulia, your comments, sir?
In my opinion, we have now ample data that after sentinel lymph node biopsy, and I'll consider this node negative because it is a micrometastatic. Otherwise, we can say it's a low metastatic burden disease. We have ample data nowadays to leave axilla. And I personally would be more comfortable treating only breast in this case. I'll not go for axillary radiation in this case. The only point going against is the age. She's quite young, right? How old is she?
42 years, sir.
42. Even in that case, I would omit.
Yes, sir. Yes, sir. Agreed.
So, Dr. Gulia, do you consider any other high risk factor?
Well, mainly we consider the molecular subtype and the stage, and of course the axillary lymph node burden, the sentinel lymph node biopsy. And if we go by the NCC, and we have other risk factors as well, LVI, ECS. But honestly, in this particular case, if we are talking about, I don't think there are any risk factors which will make me take axilla in the field. I'll omit axilla.
Thank you, sir.
Specifically in the light of Z11 trial, we have Z11 trial, which is, of course, in that trial, it is shown that some amount of axillary radiation does get, some amount of radiation does get to the lower axillary levels, level 1 and 2. And I think that is enough to sterilize any radiation, any micrometastases which are there. So I don't think there is need of taking it in this patient.
Thank you, sir. So, Dr. Preetha, what dose will you give to this patient? Dose of radiation?
So the dose of radiation I'll be giving in this patient would be the hypofractionated regimen, that is 42.5 gray in 16 fractions to the whole breast, then followed by boost to the lumpectomy cavity, that is 10 gray in 4 fractions. And this is just to the lumpectomy cavity. So we practice the hypofractionated regimen.
Dr. Faraz?
Yeah, I agree with Dr. Preetha. Hypofractionated radiation, we have data for that. And because now we are not treating axilla. If we would have been treating axilla, then I would have gone for conventional radiation, because NCCN says that if you are treating axilla, then you should be going for conventional and not hypofractionated. Although in STAR TNB, we had 15% patients who received nodal RT, and there was no difference in outcomes. Still, because we are just going for breast radiation, whole breast radiation, we will go for hypofractionated RT followed by boost.
Dr. Gulia, your take?
In my practice, I'm seldom doing the conventional 50 gray and 25 fractions nowadays. And I would have definitely gone for 42.5 in 16 hypofractionation. And it is immaterial if I am giving it to axilla. What is the target volume that is immaterial? I would have given it to, I would have followed a hypofractionation schedule. I think it's more or less standard, and as far as I know, most of the centers are following the same.
Thank you, sir. So, Dr. Faraz, what technique would you like to do for this patient?
Obviously, I will be going for image-guided techniques, if available, and including DIBH. This is a left-sided tumor. I am concerned about my heart dose and lung dose, obviously. So I will, if available, I will be going for DIBH. If not, then obviously tangential.
Okay. Dr. Preetha?
Okay, left-sided breast at our institute, we go for IGRT technique. And first and foremost, for all left-sided breast cancer patients, we'll go for DIBH assessment for 3 days. If after 3 days of assessment, if we deem the patient suitable for DIBH, we go ahead with DIBH induced treatment throughout the duration of the treatment. So we make the patient practice for 3 days with at least a separation of 1 centimeter is our threshold. So if you're having a separation of 1 centimeter from the heart, that is enough for us. That is the minimum threshold. And in all these patients will go for DIBH. If the patient is not conducive for DIBH, then we'll go with the free bleeding, but IGRT first.
So we prefer the DIBH technique because we know that 1 gray of dose can add to 9% of toxicity to the heart.
Yeah.
We'll proceed with the case number 2. So there is a 38-year-old married para-1L1 premenopausal lady who presented with a right breast lump since 2 months. She was clinically T2 and N0. On mammography, she had an ill-defined speculated marginated lesion in upper outer quadrant of the right breast of 4.2 into 3 centimeters, which was by 5. Biopsy was done, which was IDC positive, grade 2, and came out to be triple negative. Any further investigation that you would like to do in this patient? Dr. Devesh?
Ma'am, can you hear me?
Yes, I can hear you.
Ma'am, can you take me to the last slide, please?
This is a 38-year-old woman who's premenopausal, para 1. She has a right breast lump of 4 into 3 centimeters, who's triple negative. So what would you like to evaluate next?
Okay. In our institute, for the triple negative breast cancer, even for the early stage cancer, they go for the PET-CT whole body, along with the other blood investigations, and later the biopsy has already been done, obviously, and then further we'll go for the management of the patient. I don't think the MRI of the brain and the other investigation it is an early breast cancer.
Dr. Pratap, would you like to go for an ultrasound axilla in this patient?
I'd like to go for a mammography with ultrasound.
Okay. Okay. So in this patient, we did a PET scan which showed a right breast lesion of 4 into 3 centimeters, no distant metastasis, no axillary metastasis. The clinical stage was T2, N0, M0, NBC. So what is our provisional plan? Dr. Abhijit?
In this patient, provisionally, I would like to go for a neoadjuvant chemotherapy in view of TNBC status.
Okay. So our patient received neoadjuvant chemotherapy. What neoadjuvant chemotherapy would you have given, Dr. Atira?
Neoadjuvant with paclitaxel plus carboplatin plus pembrolizumab, followed by AC plus pembrolizumab.
Okay. So to the surgeons, Dr. Pratap, would you like to do an sentinel lymph node biopsy prior to doing a neoadjuvant chemotherapy?
Generally, we don't
5
do it
minutes.
prior to. Generally, we
Sorry,
don't
sir?
do it prior to surgery. Generally, we don't do it prior to surgery.
Dr. Namita, kindly wind up session only in 5 minutes.
Yes, ma'am. Post NACT, our patient had a good clinical response with more than 50% reduction in tumor size, and there was no lymph node palpable. So any pre-surgery workup that you would like to do, Dr. Abhijit?
I'd like to do a reassessment scan, better with the previous imaging modality which had been done, so that a good comparison could be made, along with a USG axilla to determine the nodal status.
Okay, so we did a PET scan which came out to be YCT1N0M0. So surgery, what surgery would you like to do, Dr. Pratap?
BCS with SLNB.
With SLNB. So in this patient, we did a BCS plus SLNB, and the histopath came out to be YPT1N0M0. So Dr. Preetha, your take on adjuvant radiation, the sites, the dose, and the technique.
Again, this is a BCS and YPT1N0 with a clinical nodal status of N0. Again, my target would still be the breast only, and same techniques. Oh, okay, this is a right-sided breast. So I'll go for again 42.5 gray, 16 fractions to the whole breast, followed by 10 gray, 4 fractions to the lumpectomy cavity boost. No need of any nodal RT in this case. The patient was clinically N0, and even the SLND was adequate and no nodes identified, so no need of nodal RT.
Dr. Faraz, do you agree with that?
Yes, ma'am, I agree with Dr. Preetha. Only whole breast RT.
Dr. Gulia, sir, your comments?
I agree with what they've said, because it was T2N0 to begin with, and now it has responded also. I would agree with the fields suggested by Dr. Preetha.
And sir, what technique would you prefer?
Well, if DIVH is available, then DIVH. Otherwise, I think tangential works very good for the breast cases.
Okay, sir. Thank you, sir. Sorry. So this is a hypothetical situation. In case 1, if the 42-year-old ER/PR positive HER2 negative patient, she opted for a BCS and her family history was positive. So what all risk reduction management could we have done? Could we have offered to her? Dr. Pratap?
If she is any BRCA positivity,
This patient didn't get tested for BRCA, but she had a family history positive.
but we will offer only for patients with genetic testing positivity.
Okay, so patient who have not tested BRCA, we don't offer risk reduction to them.
As per guidelines, it's not recommended.
Okay, sir. The take-home message is that utility of ultrasound axilla in a clinical N0 axilla is still under investigation. After 1 to 2 nodes SLNB positive, the role of regional nodal irradiation is still debatable. And when it is a clear N0 and isolate, sorry. And if there is a clear N0 or an isolated tumor cell is present on sentinel lymph node biopsy, we do not do an axillary lymph node dissection. And the molecular classification of breast cancer does not influence the surgical or the radiation management. Although the role of systemic therapy and the agents have created a dramatic shift. Thank you so much for your patience and kind listening.
Great discussion, Dr. Namita. So I would like to invite Dr. Charu Garg, Director and Head of Department, Radiation Oncology, Max Specialty, for a few lines on our presenter and for this session. Over to Charu.
Thank you, Dr. Garima. Thank you for making this session a good and a very fruitful discussion. Here, I would just like to
Can
add
I
one
interrupt
thing.
you for a moment, ma'am?
Sure, Abhishek.
Can you just put on the take-home message point number 2, the slide, the last third slide? What is your practice nowadays if sentinel lymph node biopsy 1 or 2 are positive? I mean, low axillary burden. I'm not talking about the case number 1 in which it was really a micrometastatic case, but frankly 1 or 2.
I would treat the axilla here.
Yeah,
If
same
the
here.
sentinel node was, if the sentinel node is positive, TNBC, I mean, we had a very similar case right now, which we treated, and there was a lot of controversy on that, but young patient, TNBC, sentinel positive, ALND not done, 2 nodes positive, we went ahead and treated the axilla.
So although rightly
And
mentioned,
also,
it is debatable, but even I would have gone for axillary.
it is debatable. Yes. And the other thing is what I wanted is like, I mean, we have been all talking about IGRT and DIPH, but in breast, if please try with the field and field first. If you can get good plans with that, I mean, that gives the the least dose to your normal organs. If the shape of the breast is so. And I think breast is a controversial organ. And as we have genomic profiling in medicine, I mean, for chemotherapy, there are a lot of studies which are going on in radiation as well. And I think in times to come, we will have, genomic profiling for radiation as well. So I think, thank you, everyone. It's already 9:30. So thank you all and have a very good night to everyone. Thank you.